atrial myxoma, high altitude, pulmonary venous obstruction, pulmonary arterial obstruction. Now, a point that you should understand is, apart from the etiologies, whatever we have discussed in the ARDS, there are some more etiologies which will cause the ARDS. Let me discuss and we will come back to this question here. Now, if you take the other etiologies causing ARDS, the other etiologies, they include renal and as well as the liver failure, right? Apart from this particular renal and as well as the liver failure, we have the conditions like eclampsia. So what is eclampsia? Eclampsia, remember, it is a clinical condition where the female will have a pregnancy-induced hypertension. Along with pregnancy-induced hypertension, the female will also have the seizures. Right? This is called as the eclampsia. Next, apart from this, the other condition which will cause this ARDS is amniotic fluid embolism, right? Amniotic fluid embolism. And next, what we have is, in condition of hanging, the individual may land up in ARDS, and the other condition is in conditions of the high altitude. Right, in conditions of the high altitude. So all these conditions, the individual will have what? The ARDS. Now, so if you see this question here, normal pulmonary capillary wedge pressure with pulmonary edema is seen in case of high altitude, right? Okay. If you take left atrial myxoma, right, it will be a cardiac condition which will increase the pulmonary capillary wedge pressure. That becomes cardiogenic pulmonary edema, where the pulmonary capillary wedge pressure is increased but it is not decreased or normal. And you take pulmonary venous obstruction or pulmonary arterial obstruction, right? They also constitute, you take very particularly pulmonary venous obstruction. In pulmonary venous obstruction, there will be definitely increase in the pulmonary capillary wedge pressure because there is impairment of the blood flow from the pulmonary veins into the left atrium. And pulmonary arterial obstruction, it will not affect the pulmonary capillary wedge pressure, and similarly it will also not cause the pulmonary edema. Okay, so here the answer is the high altitude. Next, now after having discussed about the etiologies, now let me tell you a question here. What does this question tells you is, like, so already we have discussed the normal pulmonary capillary wedge pressure. Yes. Now the point is, what is the catheter, right? The question which will be asked is, what is the catheter with which the pulmonary capillary wedge pressure is measured? Remember, the catheter with which the pulmonary capillary wedge pressure is measured, that is called as the Swan-Ganz catheter, right? This is your Swan-Ganz catheter, what you are seeing here. With the help of this particular Swan-Ganz catheter, right, Swan-Ganz catheter. So with the help of this Swan-Ganz catheter, you will be able to measure the pulmonary capillary wedge pressure. Now you take the, right, this is also your same, that is the Swan-Ganz catheter, right? You have almost like 3 to 4 lumens, and the catheter is directly passed up to the level of the pulmonary capillaries. Now you take the normal pulmonary capillary wedge pressure. So this is the multiple choice question here, right? You take the normal pulmonary capillary wedge pressure. Normal pulmonary capillary wedge pressure, this is around 6 to 12 millimeters of mercury. Right? Normal pulmonary capillary wedge pressure is 6 to 12 millimeters of mercury. Now you see an image here. You see this. Yes, this is good. Now what we will do is, like, first through the IJV, that is internal jugular vein, we pass the catheter into the superior vena cava. From the superior vena cava, the catheter is pushed into the right atrium. So from the right atrium, the catheter is being pushed into the right ventricle, and from the right ventricle, the catheter is being pushed into the pulmonary artery. From the pulmonary artery, the Swan-Ganz catheter is pushed into the pulmonary capillaries. Now here, the Swan-Ganz catheter will measure a pressure of nearly around 6 to 12 millimeters of mercury. Right? A point that you should understand here is, even though we call the pulmonary capillary wedge pressure as 6 to 12, when will you use the word cardiogenic pulmonary edema, or when will you use the word non-cardiogenic pulmonary edema? And the cutoff is 18 millimeters of mercury. So if the pulmonary capillary wedge pressure is more than 18 millimeters of mercury, due to which the individual is landing up in pulmonary edema, right, due to which the individual is landing up in pulmonary edema, that is called as, right, that is called as cardiogenic pulmonary edema. Right, this is called as the cardiogenic pulmonary edema. Whereas, if the pulmonary capillary wedge pressure is less than 18 millimeters of mercury, right, if the pulmonary capillary wedge pressure is less than 18 millimeters of mercury, but still the individual is having pulmonary edema, and this is called as, right, this is called as non-cardiogenic pulmonary edema. Right, this is called as non-cardiogenic pulmonary edema. Now, remember, depending upon the severity of left ventricular failure, or depending upon the severity of the mitral stenosis, the pulmonary capillary wedge pressure increases. Right, if the individual is having very severe mitral stenosis, then pulmonary capillary wedge pressure goes very much high, above 18 millimeters of mercury. Or if the individual is having severe left ventricular failure, the pulmonary capillary wedge pressure increases very high, above 18 millimeters of mercury. So what I want to tell you here is, a point that you should understand is, the pulmonary capillary wedge pressure also tells the severity of, right, severity of mitral stenosis, and as well as the severity of the left ventricular failure. Okay, so calculating the pulmonary capillary wedge pressure is a very important thing in the diagnosis of the ARDS, right, in the diagnosis of ARDS. Now you see this question, one more question like what we have. Now we have a patient, right, we have a patient who comes with the respiratory distress, right, sudden onset respiratory distress. That is how is the presentation of the patient. And you have examined the patient, and on examination you have observed, or you have auscultated, that there are presence of bilateral basal crepitations are present, which is suggesting that the individual is having pulmonary edema. And you have a report which is saying that the pulmonary capillary wedge pressure of the individual is normal, right? He has undergone recently the catheterization, or the pressures have been measured. That report was telling that the pulmonary capillary wedge pressure of the individual is normal. Now, what would be the likely cause? The options are narcotic overdose, congestive heart failure, myocardial infarction, cardiogenic shock. So, among all these, which is the non-cardiac condition which may cause pulmonary edema? That is your narcotic overdose, right? Narcotic overdose like cocaine abuse or the opioid abuse can make the individual to land up in ARDS, wherein the individual will have the pulmonary edema, that is non-cardiogenic pulmonary edema. So, you take in other clinical scenarios like congestive heart failure, myocardial infarction or cardiogenic shock. In these scenarios, the individual will have pulmonary edema, but in all these three, remember, there will be increased pulmonary capillary wedge pressure. Right, there will be increased pulmonary capillary wedge pressure. Now, after having discussed about the etiology and the concept of cardiogenic and non-cardiogenic pulmonary edema, now let me tell you the pathophysiology of ARDS. Right, so let me continue with the pathophysiology of ARDS. Now, if you take the pathophysiology of the ARDS, there are totally 3 phases. Right? There are totally 3 phases. And these particular 3 phases, they include, number 1, exudative phase. Right? Number 1, what we have is the exudative phase. And followed by the exudative phase, we have fibroproliferative phase. Right? We have fibroproliferative phase. And the third, what we have is the fibrotic phase. So these are the 3 important phases in the ARDS. Now let me explain you what will happen within the individual phases. Now first let me take up the discussion of the exudative phase. Remember, this particular exudative phase, this will be present for nearly around 0 to 7 days. Right? The exudative phase will be present for nearly around 0 to 7 days. Now let me explain you what is happening in this exudative phase. Now you see this image over here. Yes. Now consider this is the pulmonary capillary and this is the alveolus. Now what will happen in these individuals is there is exudation. Exudation of what? Exudation of the fluid. That is the exudation of the fluid from the pulmonary capillary into the alveolus. Right? Exudation of the fluid from the pulmonary capillary into the alveolus. Now, a point that I wanted to tell you here is, in these individuals with the exudative phase, there is damage to the endothelial cells of the pulmonary capillary. So here, there is damage to the endothelium of the pulmonary capillary. So capillary endothelial cells are being damaged. Not only that, there is also destruction of the alveolar epithelium. Now, because of the destruction of the pulmonary capillary endothelium and as well as the alveolar epithelium, what will happen is, right, the fluid, it slowly starts getting exudated, right? The fluid slowly starts getting exudated from the pulmonary capillary into the alveolus, right? The fluid slowly starts getting exudated from the pulmonary capillary into the alveolus. So this is a very important point that you should remember. So there are 2 clinical events which are taking place in the exudative phase. Number 1, there is damage to the capillary endothelial cells. Right? There is damage to the capillary endothelial cells. And subsequent to the damage to the capillary endothelial cells, there is exudation of the fluid. Right? There is exudation of the fluid. Next, the second event what is taking place here is, now along with the capillary endothelium being damaged, you take the alveolar epithelium. There is also, right, there is also destruction of alveolar epithelium. Right? There is also destruction of alveolar epithelium. Now, what does this alveolar epithelium consist of? Like this alveolar epithelium, it consists of what is called as pneumocytes. If you take pneumocytes, like we have 2 types of pneumocytes, that is type 1 and as well as type 2 pneumocytes. Right? Type 1 and as well as type 2 pneumocytes. right? One particular type of pneumocytes, they are required for the exchange of gases, and another type of pneumocytes, they are required for the surfactant production that will maintain the surface tension within the alveoli. Now, the capillary endothelium is damaged, due to which the fluid will start moving from the capillary into the alveolus, and the alveolar epithelium is damaged, so that is why the alveoli will try to collapse. So, into the collapsed alveoli, the fluid, it gets exuded, and that will result in what is called as the pulmonary edema, right? Initially, the fluid will move into the interstitium of the lung, and from the interstitium, the fluid next, it will go into the alveoli, and that will result in what is called as the alveolar edema. Okay. Now, so in the exudative phase, like we have seen, like what are the two important changes which are taking place. Now, you take that edema fluid which is present within the alveoli. Now, the fluid is moving from the capillary to the alveoli. So, this particular edema fluid, right, this particular edema fluid, it is rich in proteins, right? It is rich in proteins. Now, this particular fluid, which is rich in proteins, accumulates in interstitial and alveolar spaces. Right, interstitial and as well as the alveolar spaces. Okay, so this is what is happening in the exudative phase. Now, in this exudative phase, along with the proteins which are present within the edema fluid, there is also presence of the inflammatory cells like macrophages. Right, presence of the inflammatory cells, that is macrophages. Okay, now the proteins, the fluid, the inflammatory cells, all these together will form a layer within the alveoli, and that particular layer is called as the Heileen membrane. Right, that particular layer is called as the Heileen membrane. So, the exudative phase is characterized by the formation of the Heileen membrane. Right.